Hello, this is Dr. Lauterbach, and this is the lecture on LGBTQ plus and adolescent health concerns. Here's the overview of what we'll be talking about: the foundations of adolescent development and healthcare barriers, confidentiality, legal considerations, and sexual health practices, mental health challenges and risk assessments, promoting healthy relationships and inclusive care, eating disorder management and transition to adult care, roles of healthcare providers, and health promotion strategies in these groups. It's important to remember that adolescence is a distinct developmental period, not just about smaller adults or bigger children. The neurocognitive maturation shapes decision-making and risk. You will use a strengths-based lens, looking for resilience, identity, and autonomy development. Barriers to care for adolescents include access, cost, and confidentiality, poor provider communication, and a lack of sensitivity and knowledge on the part of providers. It's important to attend to communication quality and cultural humility to drive engagement with adolescents. You should plan to implement teen-friendly workflows and confidential services in the clinics and healthcare facilities where you'll be treating adolescents. There are special considerations about confidentiality and other legal matters when you're treating this age group. Confidentiality is essential for trust, and disclosure gets to be a particularly specific question. Mature minors, those over 14, may consent to limited care. Emancipated minors have full consent rights. Confidentiality enables disclosure about sex, substances, and safety. Mature minors may give consent to reproductive health care. That means that they don't have to tell their parents or their legal guardian, even though they have not reached the age of majority, which is 18 years. Emancipated minors are people under 18 years of age, but are living independently on their own. That's one way to get emancipated. Are married or have become pregnant and have children. Those are the things most commonly that will cause people under 18 to have the same consent rights as people over 18, and it is not necessary to notify anybody about their care because they can give their own consent. There are limits to confidentiality in terms of required notifications and mandated reporting, and those all relate to imminent harm, assault or abuse, and reportable infections. Those would generally be sexually transmitted infections, but they could be other infections as well, depending on epidemics in the community or whatever. You're required to report them. And that is irrespective of age. So the fact that someone's a minor doesn't cause you to not be able to disclose. Actually, you're mandated to report, and you should notify your patients of that. It's important to share those limits before sensitive questions are asked, but always know that safety will override privacy. It's important to document in your assessment and the rationale and the actions taken in cases involving minors. Turning our attention to sexual and reproductive health, a couple of guidelines to keep in mind. Normalize sexuality. Don't minimize it, but normalize it. And give anticipatory guidance and promote dual protections about what is going to be shared, what won't be shared, and the protections they have of confidentiality, which will be complete confidentiality except for those things we just mentioned that are mandated to be reported. You should ensure access to contraception and STI services and encourage autonomy and safe practices. Engaging parents is a good idea when it's safe while preserving adolescent autonomy. It's a judgment call, but when possible, you want to include the adolescent in their family unit for healthcare decisions rather than having them be separate. When taking any health history, but especially the sexual history, it's important to ensure privacy, to ask open, neutral questions, and to include gender identity and orientation and sexual practices in your sexual history taking. Provide for private time. Use neutral, behavior-focused questions. HEADS, HEADSSS, is really a helpful model. That is an acronym for Home, Education and Employment, Activities, Drugs, Sensitivity, Suicide and Depression, and Safety. HEADS. It's a commonly used model, and there's some information about HEADS in the module, but it's easily found by a quick search of the internet to get the HEADS model. There are a lot of tools out there and forms and processes that will help you in dealing with adolescent populations. It's important to, again, in a neutral way, cover identity, orientation practices, partners, whether infection protection, such as condoms, are being used, past STIs, and intentions about pregnancy. Avoid assumptions and tailor the depth of your discussion to the developmental level of the adolescent you're dealing with. This is included in the HEADSSS material, but I'm just going to highlight it here. I think one of the greatest challenges I face in dealing with this age group, and because I practice at the Campus Health Center at Wayne State University, I see a lot of older adults and older adolescents and young adults. And the stumbling block I have to always be very mindful to not fall into is gender neutral language. And if you look around on the HEAD site, you're going to see examples of interviewing in gender neutral language, but it's the simplest things. It's like if you're sitting with a female who's coming in and you're taking your sexual history or social history or whatever, it's a pretty natural thing to say, well, do you have a boyfriend? That implies that the normal state and what that person should be is straight. But you don't know that. You may not know it yet if you haven't gotten that far in the history. So always presenting things in a gender neutral way. Is there someone you're close to emotionally? Are you having sex with people? And can you tell me about that? Very neutral, very gender. It's just so natural in our culture to make everything, to use pronouns and discussions about things as though everybody was straight. But if you're not straight, then that immediately puts up a barrier and makes the patient reluctant to disclose, because it's in at least a small way, a way of not feeling accepted. So in all of that, gender neutral language is a challenge, I think, for most clinicians, and it's something to be mindful of, especially, I guess, with everybody, but especially with the adolescents. So here are some sexual development phases and milestones. Puberty to emerging adulthood comes along in mid to late adolescence, and increasing abstract thought and identity formation, whereas early adolescents and children think in a very concrete way. As individuals go through their adolescent years, they develop abstract thought, and they then develop a concept of identity in a more aware way, whereas they may have had it coming up through childhood, but the idea that identity can be described and formed is something that adolescents are are doing as a developmental task. So the milestones are physical, and they're shown here, cognitive, abstract thinking, future planning, increased independence, and psychosocial, identity formation, peer relationships, and increased risk taking. Relationships are something to be discussed with adolescents. So you want to define relationship elements like respect, trust, shared decisions, and consent. Address digital relationships and social media boundaries. This is a very potent force in the lives of adolescents and can lead them into a lot of distress. And share resources for communication skills and conflict resolution. Openly discuss intimate partner violence, its potentials, and ways to respond to it if it should occur, ways to prevent it. Some of the things to look for as a provider is unexplained injuries or isolation, depression, and substance abuse. Screen all genders for intimate partner violence. Adolescent intimate partner violence can be bidirectional. Red flags are inconsistent stories with injuries, isolation and mood changes or grade changes, that is, the performance in school. Use trauma-informed care and make sure they know about safety, planning, and referral. So now specifically about LGBTQ plus inclusive care, it's important to realize that this population is at increased risk for mental health issues and homelessness. The biggest health risk to the LGBTQ individuals in general, and especially the adolescents, is suicide. The other thing is that providers often lack training. So the risks are driven by stigma and inequities, not the identity itself. Confidentiality and trust improve adherence and follow-up. Working in a clinical setting that's treating a specific population of LGBTQ, but really because LGBTQ people are everywhere and every practice is treating LGBTQ patients, it's important to work with administration at the clinical site and the other clinicians to evaluate if you've created a safe space. So there's the display question. Display affirming materials. Show something that indicates to these people, you're welcome here. Avoid assumptions. We just talked about gender normative language, but that's just one assumption. Avoid assumptions. Just listen to the individual and their story and maintain a confidentiality within the law. So avoid assumptions, ask name and pronouns used with the family or with school, ensure private check-in, and zero tolerance for insensitivity among everybody in that clinic. It's a good idea to keep resource lists updated and active so that you can help refer your patients when they have a reason to seek care in the community or even support groups in the community. Returning to this concept of gender and sexual identity, this slide is really here to show the difference between gender identity and sexual orientation. Gender expression is personal and cultural. Gender identity does not equal sexual orientation, and this is true not only of adolescents, but of adults as well. And for some people, that may be fluid. But the thing to recall is the most important thing we need to know in terms of their physiological health, that is to say their risk for infectious disease or injury or trauma, that sort of thing. We really are more interested in their sexual behavior, not their sexual identity. To spell it out even more plainly, there are both men and women, but men, we'll say just for this example, who on a fairly frequent or occasional basis have sex with other men. We call them men who have sex with men, or MSMs. They don't identify as gay. They don't live a life as a gay person. That's not something we would judge or have anything more to say about it other than to accept that as their reality. But the point is, they're not, by their definition or any other, and their definition is the only one that really counts, they're not gay. But they have all those health risks of men who have sex with men. There are other examples for women as well. So you have to kind of understand they're different. Now, identity gets to their emotional health and their spiritual health, but it's their behavior that gets to their infectious disease risk and risk of violence. So those are things, as a clinician, you have to have a kind of a bilateral mindfulness about. When you're talking to the teens, try to mirror their language and then clarify the terms when invited. Try to get through, because things are described sometimes by people in age groups other than ourselves in ways that we interpret improperly. That is to say, we interpret it to mean something it was never intended to mean, something it might say. So use that language, especially if you don't really understand it or it doesn't make sense in the context of the conversation, and gently ask them to explore it. So you would say, I'm not familiar with using the word like that. When you say that, what do you mean? Rather than, I don't know what you mean. Being abrupt just closes the conversation. It shows judgment. It breaks down all that stuff you've just been trying to do, but just gently try to elicit. If you're hearing language you don't really understand, which I have happened to me a lot, gently ask for it. When I hear that word used that way, I don't know what you're exactly meaning. I'm not sure I know. Could you just explain to me what that means? The other thing to do is assess their family and school support, and anticipate that they're going to have minority stress. That is, the stress that comes from an awareness that you're different than the mainstream, the majority, that you're marginalized, not all kinds of ways to try to describe that feeling. But that problem, there's a nursing model called modeling and role modeling by Helen Erickson. It isn't all that widely used, but she describes that as affiliation. And that, the teenage years are this difficult time, in particular, the teen years, where people are struggling with a task she calls affiliated individuation, staying affiliated in a group and yet developing yourself as an individual, affiliated individuation. That really describes a lot of the conflicts, the internal conflicts going on among teens of all types, and it will be especially intense among teens who think they are in some way different than the family unit, or that there are expectations on them to be someone other than who they are. They have a lot of trouble with both affiliation, wanting to be affiliated and yet feeling attacked, and individuation, trying to figure out who they are and how they can live a full life being who they really are. It's not a unique thing to adolescence, but it's really intense during the adolescent years. So it's important to be mindful of that when you're talking with teens. Let's talk about screening and risk assessment. Some of the things you want to definitely deal with is substance abuse, depression, sexual behaviors that would be dangerous, and violence. Include, of course, LGBTQ youth in all of that. Use Bright Futures from the American Academy of Pediatrics. Their periodicity table for universal screening is excellent. I believe you already have it as a resource. If not, get one. You can get them on Amazon. Again, the name is Bright Futures. If you just type that in, you'll see that the American Academy of Pediatrics has all kinds of materials. I use a couple of their materials routinely in my practice. Think about getting risk-based labs. So HIV, chlamydia, gonorrhea, syphilis, trichomonas, pregnancy testing, basically STI panel, and pregnancy testing, and document private time and confidentiality of the discussion. You'd put that in the general part of your note. In your MDM, that would be probably in your plan and follow-up. Mental health is the area of greatest risk for adolescents. Adolescent depression may present as irritability or somatic complaints, so screen suicidality when indicated. Use the PHQ-A, the GAD-7, there's an ASQ out there. All of these are screenings to help identify depression and anxiety. Coordinate with the school or behavioral health in the community if you find that there is any concern, to make sure that you're providing safe and appropriate care. Violence and bullying are increasingly important in the lives of adolescents. It's the leading cause of death and injury in ages 15 to 24. Violence there includes self-violence, suicide. And bullying is linked to depression. So bullying and cyberbullying drive anxiety, depression, which could be reflected in absenteeism and isolation. You want to ask about school. What are you doing online? What's your neighborhood like? And provide rapid linkage to supports if you find a problem, and schedule a follow-up. Eating disorders are a problem that emerged during the adolescent years. Anorexia, bulimia, binge eating, and avoidant restrictive food intake disorder. Early identification improves outcomes and occurs across genders and body sizes. ARFID lacks, that's the avoidant restrictive food intake disorder, lacks weight and shape over evaluation. Otherwise, it looks very much like anorexia. Watch for nutritional deficits. ARFID is an eating disorder characterized by extreme restriction of food, but not due to concerns about body shape, as is in anorexia nervosa. Key features: persistent failure to meet appropriate nutritional and or energy needs, leading to one or more of significant weight loss, nutritional deficiencies, dependence on enteral feeding or nutritional supplements, and a marked interference with psychosocial functioning. Common presentations would be, in terms of sensory-based avoidance, sensitivity to textures, colors, or smells of foods. The fear-based avoidance would show up as a choking, vomiting, or allergic reaction episode to exposure to food. Low appetite or lack of interest in food, chronic disinterest in eating. It affects and can often begin in childhood or early adolescence. It occurs both in males and females and may be associated with autism spectrum disorder and anxiety disorders or ADHD. Distinguishing factors and features for ARFID and anorexia nervosa. Fear of weight gain is present for ARFID. Body image disturbance, that is a misperception of body image, is not present in ARFID, but is present in anorexia. The management is a multidisciplinary approach: medical, nutritional, and psych support. Cognitive behavioral therapy and exposure therapy can be helpful to expand tolerated foods. Family-based interventions when appropriate, and you should monitor these patients for growth, nutritional deficiencies, and psychosocial impact of their illness. This slide is just about anorexia nervosa by itself, so there's a triad of low weight, fear of gain, and distorted body image, and these patients is very important to monitor vitals and electrolytes. Medical risks are bradycardia, hypotension, and refeeding concerns. And the approach is family-based therapy. It has using the Maudsley model, has the strongest evidence of improvement in adolescents. Bulimia and binge eating disorders are also nutritional disorders. These are compensatory behaviors, and they can lead to things like dental erosion and parotid swelling. Binge eating disorder, or recurrent binging without purging, results in marked distress and impairment. And cognitive behavioral therapy -E, nutrition therapy, and screen for comorbidities and substance abuse is the correct approach to this if you discover this in one of your adolescent patients. This is a slide about CBTE, or the Enhanced Cognitive Behavioral Therapy. Evidence-based psychotherapy for all eating disorders. It focuses on maintaining mechanisms, over-evaluation of weight, shape and eating control, perfectionism, mood intolerance, and interpersonal problems. Structure is 20 to 40 sessions, so it's a long-term therapy. And the goal is to normalize eating patterns, improve self-worth, and to prevent relapse. Key components of any treatment plan for eating disorder management will include family-based therapy, a focus on weight restoration, and monitoring vitamin D and calcium for bone health. As adolescents move on into adult care, there are things we can do to help that transition. Promote health literacy, support self-management, and transfer readiness. So plan the transition by mid-adolescence to build self-management skills. Whether you do that from the platform of your practice or you discuss it with the family and the patient to see what other things maybe the schools are doing or other agencies may be doing to help. But it's important. This is a natural, a very common thing in families, but you want to find out how that's coming along. And you can then provide transfer summaries if they're in a plan for extra support, talking about meds, consents, confidentiality, and practices, and then a warm handoff to the adult providers as you transfer their care on to an adult provider away from, if they're going out of family and they're going to go to internal medicine or something of that nature. The point I think the author's trying to make here is avoid care gaps. Get as much information as you can to understand where they are, knowing that there's the physiological, the emotional, and the developmental concerns to be addressed, and that you don't simply retract that once they become defined as an adult. You need to have a transition plan to figure out, have they accomplished their developmental tasks, and are they doing okay in terms of their emotional and physical health, and then have a transition if they're going to move to another provider as they get over the age of 18. And I'm going to tell you about immunizations because I have it kind of as one of my causes in life. But yes, immunizations. And to do that, not in a preachy way, but in a information gathering as well as providing sense. Why, if somebody's resistant, say, to getting a vaccine, see if they will engage with you in a discussion about the barriers. And then from that, you can use the things you've learned here, like the trans-theoretical model in the stages of change. Where are they? You could use motivational interviewing. You could use health belief model. You could use any of those to craft an approach that might be effective with them to reduce the risks. Part of the role of the nurse practitioner is to advocate for adolescent-friendly services in your practice setting, to ensure confidentiality, and to always use evidence-based tools when they're available. The things I'd like you to take away from this are heightened awareness of the intention, the effort required, and the legal constructs around respect, confidentiality, and inclusivity. Legally only affects the confidentiality. But if there's something you cannot keep in confidence, you should tell your patients, irrespective of their age or any other aspect of their being. There's a limit here to confidentiality, and you need to know what it is. Comprehensive screening, appropriately, generally annually, unless somebody's extraordinarily high risk. Some are not annually, like the pap smear is every 3 years, then every 5 years if there's no HPV and so forth, but comprehensive screening up to date and collaboration with families. That ends this lecture. I'd be happy to take any questions you have by simply emailing me at clauderbach@madonna.edu.